which we are probably going to start moving more and more toward advocating in every patient, because so many times you develop these symptoms, you don't know you have AFib, and it'd be nice for you to just say, I wonder what's going on, push a button, have something transmitted to your doctor's office, and save you a trip into the office. Casey's going to go over that. She's not allowed to talk about the newer technology, which will be even better coming in February, but I can say something about it later. So without further ado, I'm going to introduce Casey. She works for Medtronic in their monitoring division. She's been with the company for over 7 or 8 years, 10 years. And she's basically in charge of this entire project for them in this entire region. So she's going to talk, and then we're going to entertain some questions. This session is being filmed and will be shown on the website. Have any of you guys been to the website yet? Looked up? These discussions are being archived, so if you missed something, or if one of your friends asks, Sharon can give you information about how to log in and take a look. So without further ado, Casey, I'll just turn it over to you.
Good evening. Dr. McKinney called me and he wanted me to discuss the little device that I have, which is called the Reveal XT. It's an implantable loop recorder. It's a diagnostic device that is to help identify arrhythmias that a patient could be having. I, in my presentation, kind of put together a couple of categories where we actually use this device for. So I'm going to kind of go over Syncope is one of them, the atrial fibrillation monitoring, and then there's also another third part, which is kind of new for us, which is Cryptogenic Stroke. It's a type of stroke that also we use the device for. So I'm going to briefly kind of go over like the prevalence of those categories, and then I'll dive a little bit more into the device itself. I don't have many slides on that, but I can just kind of talk to you all about it. In front of you, I kind of passed out a couple of demos. It looks like a USB flash drive, but that is the actual device. So real quick, a history a little bit about the device. It's been around for about 12 years. Mainly it was used in the past just for syncope patients that suddenly pass out and lose consciousness. A lot of these patients pass out because of abnormal rhythms. And in the past, or currently actually still today, let's just say I'm the patient, I've passed out before, I would go to the cardiology office, they'd put on a Holter monitor, which is the sticky things that probably every single one of you have worn, with a little monitor that you carry home. It can last for 24 days, some of them last for a week, some of them 30 days. And that continuously records your heart rate and rhythm while you have it attached to you. And hopefully they'll try to look for reasons or abnormalities on why you passed out. So that's currently what used to happen in the past. This device came out to where it lasts for 3 years. It is implanted right underneath your fatty tissue, right here above where your heart is on your left side. It can last, like I said, for 3 years, and it's continuously recording your heart rate and your heart rhythm. And inside of it, it has a ton of detection parameters to where if your heart rate goes too slow, too fast, if it goes abnormal, i.e. atrial fibrillation or atrial flutter, pauses, you name it, the device will automatically collect this data. So in the past, it used to be just used for that. And now we have new indications for atrial fibrillation monitoring, which Dr. McKinney is a specialist in, obviously, for the atrial arrhythmias. The device can detect that, depending, it doesn't matter if your atrial fibrillation rate is 40 beats a minute or if it's 200 beats a minute. It will find it if indeed you're having it. And also with that, I'll go over the stroke part on how that plays a role. But the first topic I'm going to go over real briefly, though, is just syncope and just the prevalence of it. Most of the patients in here, how many people have devices already? Pacemakers or defibrillators or real? Okay. And everybody else is kind of trying to figure out what's going on, huh? Okay. All right. Well, syncope, just briefly here, syncope is basically passing out, a loss of consciousness. 40% of the population will have at least one syncopal episode in their lifetime. 10% of the falls in the elderly are believed to be due to syncope. Major morbidity reported in about 6%. That's kind of like fractures, things of that sort. And minor injuries like bruises and lacerations are about 29% of those patients. As much as 50% of the population may experience, like I said, a syncopal event in their lifetime, and the cost of this to the healthcare system is actually huge. It's about $2 billion per year spent on patients that are admitted for syncope. And the reason that number is so high is because doctors are used to just putting on these external monitors, and they give it to you for 30 days, you come back, you hadn't passed out yet, oh, let's give it to you another 30 days, and they just keep slapping on these conventional monitors hoping to find your reason. And what you don't have is actually a continuous monitor all the time, basically inside you, and that's what this device is. So that's the reason this cost is so high, is just due to the unnecessary tests that they keep doing to try to find reasons on these things that are happening to these patients. Major impact when it comes to syncope is a lot of times the patient's quality of life. Some people have to change employment. Some people have to, resign from their jobs depending on what they are. I've implanted 2 bus school drivers that needed a device, and were threatened basically they had the first syncopal event. And some law actually requires if you pass out before, you can't drive anymore. So. They alter daily activities. A lot of people are afraid to go do stuff because they're afraid they may pass out again, and they don't know when and where, and they don't know what causes it. The main part here to look at is that the 34% that's unknown. So there's a lot of people, again, that pass out that we can't find answers to, and again, this device, this one use of it is to implant it. You're always covered for 3 years. So it could be, you pass out, and the next time you pass out might not be for another year. So you're covered. You have something inside of you that's recording continuously, watching you. So it could be 2 years till you pass out again. It could be 2 weeks. We don't know, but you are covered. You don't have to go through the whole stream of tests again when you do pass out again. So that's where this device comes into play. I mentioned these before, some of the monitors that they do hook up on you that aren't my device, the ones that are external. You have your 24 Holter monitor. That's probably the most used in the doctor's office. You go home that night, you bring it back, and that looks for arrhythmias. You have your MCOT, which is a 30-day monitor. Again, it stays on you for 30 days. A lot of patients have problems with these because you have to take them off, take showers, and they have a problem with the adhesive, and they fall off. They ended up actually not wearing them most of the time. And then again, there's mine. So that's just a little briefing, a little bit on syncope, the way the device is used. So again, it's just covering you, like again, for these syncopal patients, we don't know when they're going to pass out again. Okay, so atrial fibrillation. Prevalence stratified by age and sex. A lifetime risk of developing atrial fibrillation after the age of 40 is 1 in 4. It's very prevalent. So as you can see, there's the women in blue and men in the green. And as you get older, the chances of you possibly getting it is a lot higher. Again, the way that we find atrial fibrillation is for those monitors that we just saw. There's in the office they can just do 12 lead. That's why you're there. There's a 24. There's a 30-day event recorder. Then there's mine. AF discovery and monitoring. Symptoms are not normally reliable indicators of atrial fibrillation. And the truth is about 90% of your AF in patients are asymptomatic, meaning that patients don't have symptoms to it. Some of the symptoms I'm talking about is some people sometimes feel palpitations, like they'll feel kind of like a throbbing in their neck. Sometimes they're lightheaded, sometimes they're dizzy. A lot of patients at Afib say, oh, I just feel completely run down, I can't catch my breath. Some people get edema or swelling in their arms and their extremities. These are just some of the symptoms of atrial fibrillation, but a lot of time, the majority of the time, patients don't have any of them. So they have no idea that they have atrial fibrillation. And about only 20% of those that reported symptoms are actually due to AF. Again, when it comes to finding AF, the external monitors that I mentioned before are very low yield just because they're only on you for a certain amount of time, and that doesn't mean you're going to go into atrial fibrillation while you're actually wearing those external monitors. That day you take it off, you could go into atrial fibrillation for 6-7 hours, but we'd never know because you're not wearing an external monitor, and that again is where the implantable loop recorder comes in play. Where it can help when it comes to atrial fibrillation, once it's actually implanted, the device collects a ton of information. It collects how much atrial fibrillation you're actually in. It's called your AF burden. How many hours in the day? Is it in the morning? Is it in the afternoon? Is it in the night? How fast your bottom part of your heart goes while you're in atrial fibrillation. These are all fantastic and wonderful things for Dr. McKinney to be able to have as an asset to help treat you as a patient. can we medically manage that? And if we do try medically managing you instead of going to an ablation, is it actually working? Right now, let's say you have atrial fibrillation and he gives you a certain medication to try to break that rhythm or slow you down, and let's say they send you home with a 24 or 30-day monitor, that's only monitoring for that long, but who's to say what's happening when you take that monitor off? Is it still working as good? Has it kind of teetered off? Is it not as effective? So that's where this monitor comes into play. It's always watching, it's always reporting, and it can give him a slew of information. Another thing it can do when it comes to atrial fibrillation is it trends the data. It's got a 14-month trend and it basically, and I'll show a picture of it, it kind of gives little spikes of 24 hours in the day over 14 months. And it shows actually how much Afib you're in, to where, let's say you weren't on any medications, we found you to be Afib, and we have all these big lines all over it, and then let's say he gives you medication, so let's say he does an ablation, those lines should drop to where it doesn't show any Afib, and he can track that. And again, I'll show you a picture of what that kind of looks like so you can get a visual of that. But it's a huge, huge resource for him to better even guide what kind of ablation to give you. Dr. McKinney will probably go over this. A patient that has paroxysmal Afib that kind of comes and goes sporadically, that's a different type of possible ablation he wants to use, opposed to somebody that's a little bit more persistent, something that's lasting for a longer amount of time. That's a different type of ablation he might want to use, and this device can help guide him in that, making that selection. Did you have a question?
Yes, how do you extract that information out of the device?
The way that we do it is just like patients like have that she has a pacemaker. Basically, we bring it into there's two ways. We can bring it into the office. We put a little wand over your device, and it basically sucks all the information to a computer screen. We can do it that way, and there's also a home monitor that basically does the same thing. It puts a wand over your device. You press the send button, and it sends it to an internet where we can pull up all your information there too. Last but not least, real quick, before I go over a little bit more of the device specifics, this is a kind of new and very cool part of the device. Because it can detect atrial fibrillation, there's something called cryptogenic stroke. Patients have had strokes before of unknown cause. Okay, patient goes in the hospital, they've had a stroke, the doctor does a million different tests on them while you're there. You're normally there for a couple of days, and a lot of these patients get sent home going, we don't know what caused it, but here, take an aspirin or a Plavix, which is an antiplatelet therapy drug, and we'll see you later. We don't know why you had a stroke. That's what cryptogenic means, unknown origin. Because this device can detect atrial fibrillation, studies have actually shown, real quick, this is just a little bit of a prevalence here. The main part just to look at is that cryptogenic in these patients, it's actually 25 to about 30% of patients that have stroke actually have cryptogenic stroke. We don't know what caused it. And the more studies we're actually doing with this device, we're finding out that number is actually higher. And the reason is that we're finding a ton of these patients that actually have atrial fibrillation. And atrial fibrillation can be a huge cause for certain strokes, the embolic strokes to be more specific. Why is AF important when it comes to finding cryptogenic stroke? If you have AF, you have about a 5-fold increase in your stroke risk. So finding out if you have it is pretty important. AF accounts for about 15% of all strokes, and that's, like I said, likely underestimated because currently there was no way to monitor patients that had cryptogenic stroke before. There was no way to continuously monitor them because honestly there wasn't a device that was indicated for it. And now this is. So the more that we're monitoring and looking, we're actually finding patients that have a lot of atrial fibrillation. Let's see, again, these patients have had strokes. Most of them are non-symptomatic to atrial fibrillation, so they'd never known they had it in the first place. They never had any symptoms of it, so they had no idea. And most of the times when patients present themselves to ERs after having strokes, they're normally in normal rhythm. So AF actually doesn't present itself after they have a stroke when they get into the ER. It's normal rhythm. So, so this is a place where we've been putting in a lot of the devices as well. Again, prevalence of AF and stroke caused by age. The older you are, the more prevalent it is. It kind of goes back to the older you are, the incidence of you having atrial fibrillation is higher. So real quick, I'm just going to go over a little bit of the product overview. The device is indicated. There's two pretty vague indications. It's any clinical syndromes, and that means cryptogenic stroke, basically in that category, or and atrial fib monitoring, or any transient symptoms that may suggest a cardiac arrhythmia, palpitations, shortness of breath, chest pain, dizziness, you name it. So the doctors are kind of being a little pretty inventive, actually, with I've seen all types of patients who get these devices for all sorts of reasons. Little specs on the device, there's no wires or no leads to it, so it's very different than a pacemaker. A pacemaker has wires that actually go into your veins and drop into your heart and are fixated in there. This device, as you can see, doesn't have any wires, and literally it goes, the next picture I'll show you has where the implant goes, but it goes right into your fatty tissue and just lays there. Again, it can automatically record arrhythmias, so whether or not you know you're having rhythms or not, if you're having them, it will find them. It can be checked in the office, like this gentleman had asked, or remotely from home. It is approved for MRIs up to 3 Tesla, so a lot of these patients, especially the ones that have strokes, need to have MRIs, and a lot of patients just in general need MRIs, so it is approved for that. This is kind of what it looks like, where we put it, general area. The incision's probably about 1 inch wide. It's a little bigger than the top of that plastic part of the header, and it just goes right into fatty tissue and just slides right on in. This real quick is a report, one of the examples of reports that I was talking about how Dr. McKinney loves this. This actual report is in pacemakers. It's in pacemakers and the ICDs as well. And this is that trend I was talking to y'all about, how it works. And if y'all can see, I know it's kind of tiny, but down here at the bottom is your 14 months. So you got March, April, May, June, July, August, okay? And you've got hours in the day in the left-hand bar, and these are different, total AF burden, how much this patient's actually in AF. So let's just hypothetically say that this is me, and I have a device implanted, and I have these little spurts of AF that it's recording, and this is hours in a day, so it's going from 8 hours to 12 hours. Some days I don't have any, okay? And let's just hypothetically say that we're using this before Dr. McKinney does an ablation on you. He can figure out actually how much you're actually having of it, what it actually looks like. And then let's just say I had an ablation. Let's imagine a dotted line right here. Let's just say I had an ablation here. What the goal is that from here on, there should be not many of these marks anymore. There shouldn't be that many marks. And so that's kind of how it works. Again, these are the next graph is just how fast the bottom part of your heart goes during AFib. So if he's trying to rate control you, try to slow you down a little bit, this would be a good answer of whether that medication's working or not, because it wouldn't be so high. These bars would be a lot lower. So it's just a way, and patient activity gives him all kind of stuff for him to help better treat you. So again, that's our programmer, how we check in office or the home monitoring system. And that is about it. It was kind of a brief overview. Does anybody have any questions? Dr. McKinney, did you have anything more in detail you wanted me to kind of go over?
Well, thank you for your excellent presentation.
Yeah, you're welcome.
How many patients, does anybody here have a revealed recorder implanted? We do, someone in the audience. And we had about 3 or 4 patients who had pacemakers, right? Mm-hmm. So a pacemaker basically provides the same function, and it's nice to have patients with pacemakers because then we can figure out what's going on. One thing you didn't mention, you can't mention it, I know you can't, but that device is going to be miniaturized in February, I believe,
It will be.
and will be available to us maybe in March,
timeframe.
maybe April. So we don't usually push patients to have implantable devices, but more and more I'm coming to the realization it's actually in patients' best interest to have this implanted. We'll never push anyone to do it, but the amount of data, as Casey said, you saw those printouts, particularly if you don't always know if you're in AFib, which is to me both a blessing and a curse. The blessing is that you don't feel it, but what you don't know about can hurt you real bad. And many times we want to try to stop blood thinners. We can never make an intelligent decision without that information. Well, I mean, we'll always be in error. And one of the things I learned over 20 years is that a lot of stuff we thought we know or knew, as we're learning more about atrial fibrillation, we're we're learning so much more about it that I think this is the future for a lot of reasons. How many of you had one of these 30-day monitors put on? Okay. Y'all ever see the bill for that? Good. That's good. Because even I was surprised, you know, we kind of order them like candy a lot of times because we need the information. And yet you look at the, if you were to look at the bill, you'd be shocked because that little monitor is like is it 8,000?
It's more than 8, yeah.
Yeah, Sharon knows the data. And so sometimes we put 2 of those on in a year, that's 16,000 bucks. And then the ongoing skin irritation. Some patients, it's very irritating to the skin to have that adhesive on your skin all the time. So more and more as we start weighing the pros and cons, particularly with the miniaturization of the device, the amount of data it gives, it's triple cost effective for a patient. And the other thing we like is that, I don't know whether you notice our offices, but they're tending to become more crowded lately. Because we see more and more AFib patients, we have to do more monitoring. A lot of times we bring you in, you may say, that's all they brought me in for was just to do an EKG. Although that's important to figure out what to do. A lot of times all that information is embedded into this device. This could be nothing more than a simple phone call and spare your doctor's visit. And particularly under the new healthcare laws, I mean, we're probably going to be seeing a lot more people that are entering the healthcare system. You know, just not enough for me and Dr. Zhao to go around. So we're going to have to figure out some creative ways to get the information and yet not be obtrusive about it. So I think you're going to see us recommending this kind of therapy more and more. From what you've heard about it, let me take a quick poll. How many folks are positive towards something like this? Okay. What would be a big negative for you? What would worry about it?
Would the insurance cover?
Yes.
Yeah.
It's actually very cost effective to do this at a small fee, which is this cost of this is almost nothing compared to 1 or 2 monitors. I mean, I know you in particular have had a lot of, not now, but
Let's say if you, like you were saying, 2 monitors a year would cost you the 30 days, about 16 or whatever you said, about 16,000, and that's for 2 months that you're covered under the entire year of being monitored, opposed to this that's continuous that can last for 3 years, and it's probably about 5,000.
yeah.
And that's just for the hospital. It's not as much as that you would come out.
And the new delivery device is going to be literally through a syringe type device. You won't even need to. It can really. It won't be done in the office originally. I mean, in February, or March, but it'll eventually be done in the office. And I think
It's going to be that small?
It's
she can't.
it is
It'll be smaller, a lot smaller.
It's 87% smaller than the one that's in front of you.
Yeah. Power of electronics. Huh?
And it's got 20% more memory.
Probably the size of the place.
Casey mentioned that neurologists have become much more interested in this because they see, you know, it's not unusual. I saw a patient the other day who came in, had a stroke in the past. They finally figured out a year after the stroke that what was happening, we was having 1 or 2 days of AFib, which were totally asymptomatic, flipped a clot, converted the AFib for coincidental reasons, and they finally figured out it was AFib and went from a Plavix aspirin regimen to a more aggressive anticoagulation regimen. Now, what Casey didn't go over is this increasing data that you don't always have to present with that big stroke that one side is paralyzed or your speech is gone. This thing can cut you a million ways with little tiny microparticulate emboli to the brain, and what you get is sort of a progressive Alzheimer's type condition. That's not as well known. It's becoming more known now that a lot of what people are calling Alzheimer's is really we call it microinfarct dementia from atrial fib. So there's a lot of new developments with that going on, and I think these kind of devices are going to help us. So I'm sure she's going to be much more involved with us in the future with this. The real key to this is actually getting us into the CareLink system, which Sharon is working on right now, because if you have it and you still have to come to the office, it's good that you have it, we get the data, but it's actually better if you don't even have to come to the office. I think the future of medicine is evolving to where a lot of this stuff is going to be automated and more power put in your hands. You can almost see the time when it'll be transmitted to your cell phone with an automated diagnosis, and you can figure it out and let us know. Okay, so automation and independence from the doctor's office is where I think a lot of this is going. It's not quite there yet. It's getting close.
Very
So any questions about that before we launch into cryo?
Once this is inserted, is there any danger of it becoming dislodged?
No. No, normally when they insert it, the pocket that we recommend making for it to live in is normally really, really tight. Also, if you notice in the header of that, there's two holes, two tiny holes. That's where we put a little suture in and actually anchor it down to the muscle. And so plus even if you didn't, it's not going anywhere. It doesn't weigh enough to go anywhere.
And the new one will be a fraction of that
Yeah,
size. It'll be
Are there any physical limitations when you have this?
Nope. There are no contraindications to the device. People that, like for instance, have pacemakers, they have wires in their hearts, so it's a little bit different. They're supposed to avoid big magnetic type MRI, big generators, things of that sort. This device doesn't have any wires. There's no contraindications. So other than the healing process of your incision, once that's healed up, which takes about 2 weeks, game on, you can pretty much do anything that, according to your doctor, you can do any kind of activity and do anything you want. Nothing's going to hurt it.
So if you have a pacemaker, you should get this too?
No, ma'am. If you got a pacemaker, you don't need
It's
this.
not, you don't need
No.
one?
All the data that this collects, your pacemaker already does for you.
That's the nice thing about it. That's one of the good things about having a pacemaker.
Mm-hmm. So,
If you were to have an ablation, do you recommend having one of these after that?
I would recommend actually. This is
It's actually a consensus among the thought leaders in the field that we are probably better off just putting the device in, letting us know what's going on, and being able to make more intelligent decisions that are tailored to you, rather than play the odds and say, well, out of 100 patients, if we do this, we'll be right so many times. Getting individual information is always better if you can get it.
So if we can put it in, if you can put it in before, at least 30 days or so before, it can gather all this information for him about how much you're having of it. Is it persistent? Is it paroxysmal? Does it come and go? Does it stay a lot? And it'll better guide him on what type of procedure even to do. And then once you have it in, he'll be able to even show you a graphic of, this was before, this is after ablation, this is how much you had before, this is not as much as you have now or not at all, and maybe 2 years out, if it's still this blank slate that you haven't had any, maybe we can talk about taking it off of anticoagulation. Blood thinners.
That's where the key is ultimately getting you off blood thinners one day. If you've had a successful ablation and you don't know if you have AFib, at what point do you say stop the blood thinners? In a patient who knows they go back into AFib, the decision's easier because they can report to you if they have more recurrence. But what do you do with the patient who has no symptoms? How can you ever make an intelligent decision without that kind of monitoring?
And most patients after ablation, their symptoms are normally alleviated a lot of times. Like you might have symptoms before and after ablation you might not have any, but that doesn't necessarily mean you're not having every now and then little spouts of AFib.
So that's where I think we're going to be going, and we're going to be more. We do a lot of good things. We're not good at pushing patients to do things. But even though I think Dr. Zhao and I have been talking, I think that this is the way to go. Casey, thank you. And you probably see Casey sometimes in our office. She comes help pacemaker checks. So I'm going to talk a little bit more about the cryo balloon. We now can tell you a little bit about our experience over 2.5 years with what I think is a great technology for the come and go type of AFib. What type of AFib is that? What do we call come and go AFib? Paroxysmal. And persistent is you're in it all the time. But just a couple things about factors that increase your risk. Now, one of the things that increases your risk, we'll be flipping through slides here, is that as you get older, there's some things you just cannot control.
Step to your right.
I'm sorry?
Step to your right.
Okay.
Okay.
I'm in your camera line.
No, I want you in there.
No, don't worry about me. Just get the slides. They don't want to see you. So as you get older, there's just unavoidable things that you cannot do anything about. And part of this is genetically controlled. But there are some things that you do have control over. And the two big things I would say would be alcohol consumption and probably caffeinated beverages are the two biggest things you can control. The third biggest thing you can control is sleep apnea, and Dr. Lane's already talked to us a little bit about sleep apnea, and that is archived on the website if you want to go back and take a look at it. And it's surprising to me still when I see patients in the office how many patients are diagnosed with sleep apnea and simply just can't wear the mask, simply can't undergo the treatment for sleep apnea. And we find, and it was some paper recently in the American College of Cardiology, that if you have sleep apnea that is diagnosed but not treated, a lot of what we do fails. Okay, and that's a physical fact, and we can't get around it. So undiagnosed, untreated sleep apnea, in addition to the alcohol and caffeine, or remedial things you can look into. Of course, there's a lot of remedial things, but those are the big three. I call them the big five when I teach fellows. It's caffeine, alcohol, tea and chocolate, nasal decongestants that have ephedrine in them, or pseudoephedrine, and undiagnosed, untreated sleep apnea. Those are the five things we always are looking for, that we can actually shift the balance in your favor. Casey already alluded to the fact that as many as a third of strokes in the United States are due to undiagnosed atrial fibrillation. I've already given us some good data on that. And again, I want to belabor the point that this syndrome occurs with a wide spectrum, a wide collection of symptoms, ranging from nothing in a third of patients to incapacitating symptoms. So of those who suffer from AFib, how many of you, when you get an AFib episode, you've got to go immediately sit down and you're toasted for the day? So I know, almost. Not the worst. And some have no symptoms at all. And why that is, none of us have any earthly idea why some are incapacitated and some are not. I saw a heart surgeon as a patient recently, and just simple PVCs makes him almost unable to operate. So why these arrhythmias cause different symptoms in different patients, it's impossible to know. So again, I want to go over with you all the options. We call it a decision tree, and I like to think in terms of decision trees. And I'm always going to tell you the same thing when you present with AFib. And these are our options. One option is always to let you stay in it. Okay? Now, if you're incapacitated with symptoms, that's not a good choice. But in patients who are older, who don't do a lot of physical activity, who don't have a lot of symptoms, it's still medically acceptable to do nothing. But the caveat with that is you have to stay on blood thinner. What's the primary goal in AFib treatment? Is to prevent a stroke. It's not to restore normal rhythm. It's always to prevent a stroke, or what we're now beginning to realize is the decline in cognitive or thinking ability because of recurrent microstroke. So the first goal is always stroke prevention, but one option is always to let you stay in AFib. But for most patients, they go through the cycles of what? Heart rhythm drug, cardioversion, heart rhythm drug, cardioversion, over and over again. The reason is the drugs are so terrible. I mean, we've got lousy options, and none of the drug companies, because of litigation issues, are developing any new heart rhythm drugs. Or not here in the United States. In Europe and Asia, they are developing a few new ones, but it'll be years before they reach us. So I'm basically dealing with the same tools in the toolbox I had 20 years ago. Not much has changed at all. So we don't have these options. And then the last option is some type of procedure to alter the atrium to where it doesn't fibrillate or prevent the triggers of it. So those are basically the three major roads we can go down. And I guess a lot of you have heard my spiel on that already. But it's always good to reemphasize what are the options. What's the cards on the table? What can I do? And it's always good to review that. There's a lot of patients ask me this question. If I could avoid AFib, if whatever you do stops the AFib and we can prove it, do I have to take blood thinners? And unfortunately, there are people in medicine that market this idea that if we do something and we fix the AFib, can I come off blood thinners? Unfortunately, there's no big paper that tells us that's doable. In practical terms, we do it, and we've never had a bad outcome with that. But until the paper comes out, that's speculation, and that's just the truth. There's some idea that if we could keep you in normal rhythm, you'd live longer. That's unproven. So a lot of things that make common sense to you don't always bear up because there's no data to support it. Now, it's probably true, but we just can't prove it. So what I want to talk to you a little bit more tonight is the technique we use for the come and go Afib. So I'm going to skip some slides and give you an overview about why it works. And the technique is called the Cryo Balloon. And I was just talking with Ken in the back. We started our Cryo Balloon program. I think it was the first one in the state of Louisiana 2.5 years ago. We have now done over 250. So we've got a lot of patient experience to tell you what works and what doesn't work with it. We can answer some of that after. And I'm going to skip some of these slides about the rationale for letting you stay in Afib and get right to the cryo balloon. Now, what's the rationale for doing these types of things to your heart? Okay, and the real breakthrough for this in terms of non-drug treatment came from a Frenchman by the name of Michel Hasseguer in Bordeaux, France. And what he did is he took a catheter and went into a catheterization laboratory and had patients in there all day, and he painstakingly mapped where the triggers for the Afib come from. Okay? And that's important information. What he found was, this is a cartoon model of the heart. The upper chambers on your left is the right upper chamber, and on the left is, I'm sorry, on the right is your left upper chamber. Gotta get my right and left together. Left-handers are always kind of, you never figure out right and left. What he found was all those little dots up there are where most of the Afib came from. And what he found out was those blood tubes that empty into the back of the heart, the pulmonary veins, are where the Afib comes from in the come and go Afib. Now, once the Afib is set off, once the genie's out of the bottle, it's a different disease. But the disease where you get it, you have a few minutes or a few hours, and then it stops on its own, that's the paroxysmal Afib. That's the technique, that's the kind of condition that this technique is best used for. And this is a model of a pulmonary vein, and what it shows is that those blood tubes, instead of being smooth, are filled with tissue that during embryonic development, during the first 3 months of life, instead of that tissue getting out of there, it got trapped in there. And that's the spark plug for the Afib. Those are the cells that fire repetitively and set you off into Afib. So what Dr. Hasseguer did originally was he took a catheter and he hooked it up to a surgical Bovie unit, and he basically burned a circle around those veins. Okay? And so you see in the green lines, that's a circle around the veins. And what does that do? Well, when that heals, it heals with scar. Just like if you cut your hand, it heals with scar. And that scar is electrically like an insulator. So those signals that are firing, those spark plug cells in those veins, they can't get out. The blood still flows through there, but the triggers are trapped. Okay, that's what the procedure does. It traps the triggers. That's why it's called an isolation procedure. Now, the heart doesn't like necessarily to be burned. So there are obviously some complications with this, one of which is that the esophagus that runs behind the heart, that's why patients who have esophagus pain, it feels just like a heart attack. I know one of our patients here who knows that pain very well. So this procedure does have risk, burning those circles. And one of the risks is that you could burn a hole through the heart into the esophagus, and that's obviously a major disaster. Fortunately, it's never happened to us. There's 3 cases now in Louisiana where it's happened. I know about that because I was asked to provide legal opinion on them. Because obviously, they all turned into lawsuits. But this is the way we used to do it, and I don't expect you to understand all of that. But what you can see up there is a catheter, and this is in the left upper part of the heart, and you basically have to painstakingly draw that circle to try to isolate the vein. And what you see electrically is that you see those spikes on the left? Those are the electrical record of those cells. And when you finish, all of that is quiet. So that's, you basically reduce the voltage inside those veins. Now, what we think is a better way to do this, and it's a technique that's our preferred technique at EJ. We don't use any other technique, is that we use a device called a cryo balloon. I'm just going to skip through a bunch of these slides and get right to the meat of it. This is the cryo balloon, and we have a model of it. Yeah. Can you? This is the cryo balloon. This is obviously a model that has not been put in human tissue, and it goes in deflated. Ken's nice enough to put the. Oh, we don't have that, but it obviously goes in deflated. It goes in through the femoral vein. The femoral vein is a conduit into the right side of the heart. We cross into the left side of the heart, and the balloon, this is magnified, sits in the vein. And what happens is when you pump nitrous oxide through this, it gets very cold. It's like a big inflatable ice cube. And so when you touch that through the vein, it causes a rim of tissue to be destroyed, a tiny rim of tissue, and that heals with scar. So instead of burning the tissue around the vein, this freezes it, and it causes that to get a scar, and that scar is electrically silent. So this is the cryo balloon. This goes in, it's temporarily put into all the veins, okay? We freeze all the veins. This is done under general anesthesia, and then we get out, okay? And I'm going to pass this around so each of you can hold it. Now, this is technically, I hate to say it, technically a very easy procedure. So I know you think I've got a lot of skill, and I do, but this is actually, you could train a technician to do it. It's not a very difficult procedure. There's a lot of technique to get it to certain spots, but this device does all the work, unlike the catheter-based procedure where you have to painstakingly be very meticulous. It's a very difficult procedure technically. This is not a technically difficult procedure.
How long does that procedure take?
Okay, so we will typically start a patient, and Ken's been in a lot of these, we will typically go into the catheterization laboratory at about 7:30. The anesthesiologist puts you to sleep. Typically at 8 o'clock I'll start in the groin, and we are typically finished by the 9:45 or 9:30. We've gotten a lot faster at it as we've gotten more experience with it. We now have a 250 patient experience with it. And this is a technique we think is the better way to do it. Now, there are other heart rhythm specialists in New Orleans that would disagree, so there's an honest difference of opinion about what's the best way to do it. But in our hands, we're getting very good results with this, and I'll show you the original clinical trial and what the results are, because I always tell patients the downside of any procedure for atrial fib is what? Okay, let's take the worst down, okay? What's the worst thing that can happen in a procedure? What's the worst thing that can happen going to the mall? Somebody robs you and kills you, right? Or you can't get a parking space. Okay, but the worst thing that can happen in any procedure is death. The risk of death with this is tiny. It's about on the order of 1 in 5,000 and 1 in 10,000. The risk of stroke with this is probably about 1 in 200, but it's much less than not dealing with the Afib. Okay, so when you think about risk, you have to think about what's the risk of doing it versus what's the risk of not doing it and continuing to have episodes of Afib. And then another risk is that we damage the blood vessels in the leg, because as you can see, this is not a tiny little tube, it's a fairly good sized little tube, so you can damage the blood vessels. But as Sharon has heard me say probably more times than she wants to hear, the biggest risk of this is that we put you through it and it doesn't work. Okay? We put you through it and it doesn't work. And why might it not work? Let me go back to a slide I showed you earlier. Why might this not work? It's because if you look at Dr. Hatziger's original work, you'll see little dots that are not around the pulmonary veins. So in some patients, these triggers come from outside the spots we go freeze, and there's no way for us to know where those spots are. So it's a procedure that's done the same in everybody, but not everybody's the same. So it has a built-in about 10% failure rate right off the bat, because some of the triggers are outside where we freeze. So as I was saying earlier, what's the biggest downside to this is that we put you through all this, and you come out, and you go home, and then 3 months later, you're right back to where you were. That's a limitation of all these techniques, and anybody who tells you otherwise is misleading you. There is no technique right now with a 99 to 100% success rate. It just does not exist. in the United States or in Europe or in Asia, anywhere. There is a way to get 99% success rate, okay? But that involves sawing the chest open, having the surgeon cut the atrium into little pieces, and then manually sew it back together to physically alter it to where it cannot fibrillate. They actually do get 98% success rate with that technique, but I don't think anybody here is jumping to go have it, although we have had patients do it, and it does work. But it's not a technique I would actually recommend. So it does have a built-in failure rate with it, and that to me is, I hate to, you know, when I was doing my training, we were taught that if you have to come back and do a second procedure, that's a failure on your part. So we don't like to do second procedures on anyone.
Yeah, I was going to ask, if the first procedure doesn't work, do you normally perform one with the cryo blade, as opposed to, like, I can understand it not working with the
That is an excellent question, but I'll ask you to hold it just till the end, because I want to go over that topic specifically about what's our approach. Our approach is a little bit different. There are many heart rhythm specialists in the United States who will do this 2 or 3 times. We don't believe in replicating what didn't work again. And we have a different approach to it that we think is the best approach, but that's our opinion. It's not scientific fact. So I just want to show you a little bit about what the national results are. This is a schematic of the device. On your left you see the balloon, and it's hooked up to a big console. We usually have a technician there. We say inflate. The balloon's inflated. We freeze for 4 minutes each vein, then we deflate the balloon. I just want to show you, I'm not going to go into all the technical details about how this works, because I don't think you guys are that interested in that, although if you want to, we can come back and go over some of this. But here's a X-ray of the balloon in a vein, and we inject dye, that dark material up there in around 1 o'clock on the clock face. Is what we're trying to do here is show that the vein is occluded and it's got a good fit. You can let it stay in the blood pool, it doesn't do anything. It doesn't have any effect. So I'm going to show you some data of the STOP AF trial, which is where this is the trial that led the FDA to approve this device for use in the United States. And I'm not going to go over the technical side. I just want to show you one slide, because this is asked all the time, in that if I have a procedure versus whether I take medicines, what is better at preventing AFib from coming back? And I know you're all not used to looking at these kind of slides, but this is basically a graph with time here and success rates on the other axis. And with the cryo balloon, 70% had no recurrences of AFib out to almost 500 days. Okay? And if you took drug therapy, you can see how abysmal that is. So if you've got to compare drug versus the cryo balloon wins hands down. It's not even close. So if you're very symptomatic with AFib, this data is very good. Now, we now have the 2nd generation balloon, which actually gets colder, and so the latest data that was published shows that on a first try, a single procedure success rate with the cryo balloon for the come and go AFib is roughly 85 to 87%, which is very good. And I think that mirrors our experience. We have a Tulane fellow right now who's gathering all of our data. Dr. Zhao let me down on this. He hasn't put it together, so we have a young, ambitious guy who's going to put it together and publish it for us. But again, the procedure definitely is better than drugs in terms of, if you ask me the question, what's better to keep me in normal rhythm, hands down, the cryo balloon is better. Okay? Now, I'm not going to go over a lot more of these because I want to take some questions, but I do want to show you what we do to answer your question, what happens if this fails? Okay? And who is a good candidate for this? And even some of the doctors don't really understand who's a good candidate for one type of procedure or another. So this procedure is good for the come and go AFib. Okay? But if you've been in AFib for more than a month or more than a year, the FDA has not approved this device for that use. So we have to disappoint a lot of patients and say we can't use this device. It's just not, we can do it off-label, but it's not approved. So what we do and I'm going to skip through a lot of this stuff, is instead of doing this 3 times or 4 times, like even in Pennsylvania, the hospital, the University of Pennsylvania will do this 4 times or 3 times, and they actually have the nerve to publish the data, you know, but they believe in what they're doing, and I don't know what's right or wrong because we don't have a randomized trial to tell us what's right or wrong. But the approach, oh, I didn't include those slides. But what we do is for patients who have the persistent type of AFib, we use the talents of Dr. Brothers, our surgeon, who makes a little incision here under the breastbone, slides a catheter on the backside of the heart, and cauterizes the backside of the heart, and that tends to make the atrium non-fibrillatable. And then we come in with this, and we attack the pulmonary veins. That's our approach. And we're putting our data together. We think it's the best way to do it. We think that if we took 100 patients with AFib, we're going to get the best success rates. But we're not going to get 100% success rate. And that's one of the things you have to think about if you're contemplating a non-drug approach. Particularly if you're not that symptomatic with it, do I want to put myself through this if it doesn't bother me a whole lot? That's a big question. So our approach is if you have the come-and-go paroxysmal AFib, we think you're a good candidate for that. We've got a poor lady on the West Bank who's had a greenfield filter put in, which blocks the vein. We can't do anything to help her. So there's some reasons why you can't do it. But for the most part, this is applicable to almost everybody with the come-and-go AFib. And for patients who have the long-standing AFib, we utilize the talents of Dr. Brothers in what we call the hybrid procedure. And we've now done, if you pool all that together, we've now done over 350 of those types of procedures. We think we're the most experienced center, at least in the Gulf South, doing the combination of the two. But again, even all that experience can't translate into 100% success. And as we always say, when you look at statistics, if I quote you a 90% success rate, and you go into the procedure and it fails, for you it's 100% failure, right? That's the thing about statistics and informed consent, because that only applies to 100 people. It doesn't apply to you. There's no way medicine can give you a guarantee with any of this stuff. So with that kind of overview, again, this will be archived if you want to look over it, or if you want some more technical details, I can go over that with you individually maybe, or in private discussion. But that's our approach at EJ. This is our follow-up now in almost 350 patients with the combined approach. And I'll stop right here and answer any questions about.
Repeat the questions if you.
Yes, ma'am.
Did I understand you say that while you're having the procedure done, there's a 1 in 200 chance of having a stroke? Or that's
A 1 in 200 chance of a small, well, of any type of stroke. The majority of those strokes they're more like TIAs. A permanent residual stroke is much less. But you have to remember that, let's say for example, you come to see us and you don't want any procedure done, and you're in a moderate risk for stroke. Let's say we measure that with something called a CHAD score. If we do nothing, and you keep having AFib, your stroke risk may be as high as 3 to 8 to 12%. Okay, most patients don't understand that data because it's not reinforced to them that the presence of AFib by itself carries with it a bad outlook. And so when you look at a risk of stroke of 1 in 100 or 1 in 200, it's a fraction of the risk that you have if you don't have that type of procedure. So you were correct in what I said, but usually they're small strokes.
And so, but it's a small stroke.
Yes, ma'am.
A major stroke.
We have.
And you would know at the time?
We've had in the 350 total cases, the only stroke we've had was a bad stroke. It was done with the convergent procedure in a patient who had refused anticoagulation, and it affected the back part of the brain where vision occurs. So this patient's visual field was cut off partly, and he had trouble seeing around a room, which meant he couldn't drive.
That's because of a blood clot being present?
Because of a blood clot that formed after conversion back to normal rhythm. The atrium many times is stunned, and you can still form clot. He would not take blood thinners. He refused them. I'm not saying that's his fault. It may have happened whether he was on blood thinners or not. But I'm just saying of the 350, we had one. But it was a bad one.
Taking the blood thinners would lessen that chance.
It would lessen it. One thing you have to remember about blood thinners is that you hear all this hype about blood thinners, but blood thinners never take the risk of stroke to 0. That's a gross misconception about the use of blood thinners in AFib.
They decrease it markedly, but they never take it to zero.
And how long do you think you would have to be on that before the procedure?
We like to have patients, it depends on the type of AFib. If it's the come and go AFib, we're not as stringent, but the persistent AFib, we want you on it for at least 2 months.
What is the length of the hospital stay and recovery time?
Good question. So the recovery time with this is fairly quick. With the cryo balloon, you have the procedure. We like to do them early in the morning, although lately we've been having a backlog and we've been doing them in the afternoon. You will have the procedure. We usually finish by 9:30, quarter to 10. You're back in the recovery area an hour later. You go home the next day around noontime. Usually walking that same day 6 hours later. Yes, sir?
If you have the combination, how many days?
Okay, good. If you have the hybrid convergent procedure, it is about 2.5 to 3 days, a little bit longer. It's a bigger procedure. In fact, we did a surgeon, an anesthesiologist today from another city, and he asked me that because he wants to go back to work on Monday. I said, well, that's a little bit stretching it, but typically 3 days.
And if it is successful, how long do you stay on the drugs?
Okay, so what we do is, because you don't start counting the results until the heart heals. Typically 2 months, you may have more AFib, and sometimes it gets a little worse for a while. But you start counting success or failure at the 2-month mark. And that's why we think what Casey's team has with this implantable device is where we think the future is in terms of monitoring to know whether it's worked. We don't remember all of our successes, but we know every failure with it. I can almost count them. It's very disappointing to go through all this. There are downsides to it. It doesn't work in everybody. But when it works, it's beautiful. It's really nice because what Casey showed you on those little counts of the AFib, it'll go from dark, 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 dark to nothing. And it's just like, wow, we get pretty pumped up about that. So basically a day and a half for the cryo balloon, and then we usually say no work for about a week. Take a week off. Yes, sir.
Do people that have had this ablation report any pain or discomfort?
The cryo balloon is a little discomfort in the leg. There's a little bit of cough with it because the bronchial tubes are not far away from where you freeze, and you create a little bit of a bronchitis, which usually resolves in a couple weeks, but it's usually a dry bronchitis. You're not bringing up phlegm. Usually it's a little bit of tenderness in the leg. Very rare to get pericarditis, which is an inflammation around the heart sac, but sometimes you'll take a deep breath and it'll be like a little stabby pain. But it's surprising, for what we do. Now with the radio frequency, yes, we have a lot of, this is better. This is what I would do on me if I needed it. I wouldn't do it, I'd let Dr. Zhao do it. He's actually better at it than I am.
You mentioned the heat. When you go in radio frequency, you can burn through the esophagus.
Yeah, you can do this with the cryo balloon, but it's much, 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 much more unusual. Now, there's a division of thought, I'll be honest with you. There are some heart rhythm specialists around the United States that favor the burn approach. They're very good at it, and they get great results with it, and their argument with that is that they can create a bigger circle with the radio frequency than you can with the balloon. But when we do the mapping after, and we put our catheter, which has a voltage meter that we hook up to our machine, we find that the amount of isolation we get is as good or better than we had before using radio frequency. So we don't buy into the argument. But different people will give you different opinions. I'm sorry, did I answer your question?
It did, but Dr. Giles did mention something to her, that the nerve for your diaphragm is right there too.
We have not had one that's a good point. We have not had one that has been persistent. If you look at this is what he was talking about, phrenic nerve palsy. Mm-hmm. We don't have a heart model. The phrenic nerve runs right next to one of the veins. And we usually pace that phrenic nerve, and when we see it stop responding, we know that's trouble, and we get out and stop. We've not had a persistent one that's lasted more than 2 months. In the clinical trial, it was 11% of the procedures, but almost 90% of them resolved by a year. And frankly, they were still on their learning curve. It is a possibility, but persistent damage to it is pretty unusual. That's a good point, thank you. I usually gloss over that, but, because we think it's a manageable thing that we can stay away from. Yes, ma'am?
Do you think that the freezing is safer than the burning for the esophagus? Is that why you prefer it?
I personally believe that. I personally believe that, yeah.
So less
We've
risk.
never had a complication with the esophagus. It's possible, but you know, the esophagus is closed. Now we use a monitoring probe in the esophagus to look at the temperature. That helps us, and if we get too cold, we stop the freeze. But that is a potential. We think it's worse with the radio frequency, the burning, than it is with the freezing. There's also a laser now. We don't know how that's going to fit in, but we've been very impressed with our results with the cryo balloon because we think we select patients well for it, that the patients we have the come and go AFib. We do have recurrences, but with that second generation balloon that gets actually colder, we've been very impressed with it.
So what's the, you say success? Is success 100% off, is fixed, or is it 75% better success?
Okay, there's all kind of definitions of success. It depends on how symptomatic you are, but in general, success that the FDA wants us to use is that there's no symptoms, sequential monitors show no AFib for more than 30 seconds. It's a very stringent criteria. If you include success as patient had incapacitating symptoms and now may actually be controlled with medicines, that success rate's much higher, but the formal definition of success is that there's no symptoms at all, total symptom relief, and there's no measurable amount of AFib activity for more than 30 seconds. It's an extremely strict definition. We've had patients who were basically incapacitated with AFib. The procedure technically failed, but they're 90% better. And that technically, by FDA criteria, is a failure, but to us, we think it's a
sure to the patient
success. How many have had cryo balloons? Okay.
I had an ablation with you
Or was it cryo balloon?
at Tulane.
It's long ago.
No, we didn't have cryo balloon at Tulane. That's why I left Tulane. They wouldn't hide it for me. That's exactly why I left Tulane. Actually, many reasons, but I left because they wouldn't buy the cryo balloon. So we think it's a good thing. If you have friends that you think have these problems, it's sometimes, you know, the general primary care doctors don't always know about these technologies. They tend to be more conservative with it. We think we've got something that's moderately effective, moderate to, let me rephrase that. We have something we believe in is a good choice for some types of AFib, and it's very safe. We think the cryo balloon is the best way to do that. Any other questions?
The only question I have, you may not be able to answer. So she's livable what she's got. So she can go get this put in and go do the ablation. Should she wait till the smaller one comes, which is March?
Well,
She's too close. To me, that's too close.
How bad are you?
She's,
This is a public forum, so you feel free to answer that question or not. But
What do you mean, how bad?
how bad is your AFib? I don't remember your status, whether you're preparing for procedure or not.
No, it's the come and go, and I mean it can last up to, the longest it's ever lasted was 36 hours.
That's pretty long.
and that's rare.
That's long enough to form a clot, actually.
Okay.
Patients ask us a lot, how long do you have to be in AFib before you form a clot? No one really knows, but there are doctors around the country who speak at the meetings who say they've seen this develop within 2 or 3 hours of going to AFib. Typically, it's the number that is used as a rule of thumb is 2 days. After 2 days of being continuously in AFib, your risk of clot formation goes up if you're not on blood thinner. That's why these new blood thinners are so helpful to us, is that unlike Coumadin, which takes days to build up and get an effect, if you take a Pradaxa or a Xarelto or an Eliquis, you get instant, immediate anticoagulation within 1 dose. That's why I think those drugs are great. We prefer the newer drugs. The downside is that they're more expensive. Like anything in medicine, the new stuff gets priced high, because it takes about $1 billion worth of development for the companies, and they're going to make their money back. Any other questions related to this? We wanted to specifically focus on this technology because we want to archive this too,
that you can look at it. We wanted to show you, one of the patients, was it you that wanted to see the model of it?
Me?
Yes, ma'am.
No.
There was another lady who was coming tonight, I can't remember, she wanted to actually see what it looked like. Because, you know, it's, the more you know about this stuff, obviously, the better you are, right? I mean, you don't want to put yourself through something you don't really understand. I don't know if there's any other comments that we can make, or...
I have a question.
Mhm.
The lady who spoke before said that...
Casey
said that it would be better to put the Medtronic in before the ablation,
yeah, I think that's better.
and so you'd be doing 2 different procedures instead of doing one.
Well, the way we foresee it back, we're in December now. If we're getting approval in February, you're looking at doing a minor procedure. I'm not going to be doing it. I don't put devices in, but Dr. Zhao, my partner, one of the cardiologists, can do it. Put it in. I think it's better. We're never going to push you to do that.
Right.
I'm not going to say as a prerequisite, if you want to do this, you have to have that. That's not my philosophy of practicing. I personally think it's better. And of course, I'm such an obsessive that it was me, I'd want to have it in, but you'd be offered the option of putting it in. And we think if we do it, it's better to put it in before, let that heal up, and then we can get a pattern of the AFib. What we find sometimes, it's interesting, is that it's not always AFib. You diagnose with AFib, and then if you have one of these monitors, it's actually atrial flutter or an atrial tach. We've actually been able to go and do a less aggressive protocol because of the knowledge you get from the reveal and spare you the bigger procedure. I always tell the story about, you know, particularly in the, I haven't seen it lately, but when I was at Tulane, patients would, you know, Cleveland Clinic was a big center for doing ablation for AFib. A fellow there by the name of Andre and Natalie is a world expert in ablation. We had patients who self-referred themselves up to Cleveland Clinic and would have this humongous procedure done, and then later find out it wasn't AFib at all. It was a rhythm called SVT, which was easily fixable, and at least 2 I can remember, we went back and fixed SVT, and that's what they really had. So they had a really big unnecessary procedure for nothing. That's the kind of data this kind of thing gives you.
Just to elaborate on your question, ma'am, about currently, if you, let's just say you just have the reveal put in, it's an outpatient procedure, you know, they come in the morning or whatever they schedule it, probably waiting around takes longer than the actual procedure to be done. Once you get into the lab, from the time they just numb it up with some lidocaine and make the incision to out, the procedure usually takes 15 minutes. You get to go home that same day, like normally about an hour or 2 later. And then they would bring you back a month or 2 later for the following the ablation procedure. And now, the one that the lady in the front and the woman in the front were talking about, let's just say wait till like February, March for the other one. That procedure is going to take a whole lot less time, and it won't be necessarily in the cath lab. You will have it in the hospital, but you'll just have it done like in some kind of pre-op type area, things of that sort. And it's same thing, you get to go home the same day, and it's a lot less. It's a quicker procedure, but the device ultimately is pretty much the same, it's just smaller, the newer one. But so I guess it just depends on if y'all have ablation scheduled and you want it before or what not. But yeah, it's very quick though. Either one is very fast and very minimally invasive.
I'm going to make one more point about the patients. We have the persistent AFib, typically an older patient or someone whose doctor thinks that accepting AFib as a rhythm of choice is a good option. We get sent a lot of patients, sometimes 2 to 5 years after diagnosis. We did one patient 20 years after diagnosis, which is rare. But the older way of doing this was to actually go into the chest. This is the surgeon would actually, instead of opening the chest through the midline, through the sternum, the breastbone, they would punch holes in the chest and insert this equipment to externally create block around those pulmonary veins from the outside. This is the instrument going through the chest wall. The reason we moved away from that is my partner at Tulane had this done on himself for AFib, which was just driving him crazy. And I took care of him after, and he said, Jim, he said, you know, this is not the small procedure I thought it would be. Because you can imagine that hurts like hell when you wake up and taking deep breaths. The way we do it now, we don't go through the chest wall. The surgeon makes a little incision here, patient's recovery time is much better. That's why we think a hybrid convergent is much better than sticking stuff through your chest wall. So we moved completely away from this so-called mini maze. You may have heard that term, mini maze. We don't do that. We rarely do that at all anymore. We don't believe in that as much. We think our results with the hybrid convergent are better. But you can imagine this is not a pleasant thing to have, you know. A lot of surgeons around Louisiana still do this. We have completely moved. We think it's, I don't want to use the best term. We think it's archaic. Success rate with that for persistent AFib was about 75%. 70-75%. One thing they could do with that we can't do with the convergent is that little pouch on the outer part of the left atrium where the clots form, it's called the atrial appendage. The surgeon could clip that. And that may have been one of the best benefits of that, because if you clip that, there's less place for clots to form, and many people think you don't need to be on blood thinners if you have the appendage removed. So you can't do that with our current procedure.
Now, then that brings another question to mind. Can you have the atrial appendage fixed like that at the same time you're having the cryoablation?
Yeah, it's a great, you've got some great questions. In February, maybe a little bit later, the FDA is probably going to approve a device called a Watchman device, which is a device that can be inserted at the same time to close off the appendage. And the preliminary trials are very good. Patients who were compared with no warfarin, no blood thinner versus blood thinner, who had the Watchman device actually did better with stroke risk. So you have to remember, when we use blood thinner, we're trading one problem for another problem, right? We're trying to prevent clots, but bleeding is a problem. And particularly if you bleed into your brain or spinal cord. Sharon will tell you the story of one of our younger 42-year-old patients who was paraplegic for about 2 weeks because he slipped and fell. He was on Coumadin. He had no other medical problems. He slipped and fell, and he developed a spinal cord hematoma that the neurosurgeon quickly got to him and saved him. It took 2 weeks to recover all of his function, but bleeding is bad. And we're trading one thing for another with blood thinners. So, okay, folks. I hope y'all learned something from this. And again, it will be archived. If you get on the internet, you can look at this again. If you want to just send questions into us, we can call you and answer them. We like to teach about AFib. We think the better you know about these things, the better off you are. The unfortunate thing about 2013 is as of this date, there's no guaranteed slam dunk way to get rid of AFib. We're better than we were 5 years ago, and a year or two from now we'll be better, but we're not in the promised land yet for AFib treatment.
That'd be another reason not to have a mini maze, because 2 years later, technology creates something that can fix it.
You know, I've got some patients who are actually angry about this. They said, because speaking to me, you said this was the best option. Well, back 5 years ago, it was the best option, but in 2013, it's not the best option. The best thing to happen would be if somebody developed a magic pill that specifically acted on AFib, was affordable, which none of the new medicines are ever affordable, is affordable. You take it once a day, and it doesn't do anything else except stop AFib. And one day we'll have that, because scientists are learning how to selectively attack the channels for AFib, but it's not there yet.
There's still no idea of what causes it initially, though, is there?
Our understanding of AFib is at a very crude level, very crude. We have a lot of shotgun approaches. We attack the triggers, but why are the triggers actually firing? I think once we start understanding that, we understand how AFib propagates through the atrium. That's very difficult. Some of the best minds in medicine are working on it, and they're confused. It's funny to go to one of these mechanisms in AFib conference, because everybody argues, which usually means that nobody knows anything, right? We do know one thing. If you cut the atrium into pieces and sew it back together, that works. But other than that, we don't know a lot. Yes, ma'am?
Have y'all had any problems with people building up too much scar tissue, like keloids or from regular?
I mean externally or from the
Well,
leg?
no, I mean internally, you're saying you wanted to build up scar tissue
No.
to stop the misfiring.
No, we don't. There is some interesting data coming out of Utah, which will probably affect how we practice, and that there are some patients, no matter what you do, nothing works. And if you could know that ahead of time, you wouldn't do anything. You'd leave them alone and just treat them as best you could. You wouldn't put them through procedures. And what the University of Utah group found, it's still subject to verification, is that when they put patients through an MRI machine and they process the signal a certain way, they could actually see the amount of scar in the upper chamber. And patients who had too much scar, nothing worked. And if they had just the right amount of scar, almost everything worked. And so if you could know that going in, you could really be smart about what patients are subject to a procedure. Unfortunately, we do not have delayed enhancement MRI techniques here in South Louisiana. We don't have it yet.
Let me make sure I understood you correctly. Right, because right now I'm on Multac.
Okay.
Okay, so if this is successful, I would be able to get off the Multac?
Okay, so our protocol for this is that if you're on an antiarrhythmic drug before, you continue it through the first month or two, and then we see you back in the office. Our follow-up protocol is we see you at 1 week to make sure your leg is okay from the little hole we put in the leg with that. Make sure it's not bleeding. And then every month for the next year we see you. Okay, and if at 2 months you've not had any symptomatic Afib, we stop the Multac. Okay, we wait 1, 2, 3 months, and if you're on blood thinner, the blood thinner is always the last thing to go. Why is that? Because if you stop the Multac, we might technically put you at risk for more Afib, and then that's our last line of defense against stroke. So the blood thinners are always the last thing to go. I'd say the bulk of our patients who've had the cryo balloon are coming off the blood thinners and the antiarrhythmic drugs by 4 to 6 months. If you have persistent Afib, it's a much tougher story. Because when you're in persistent Afib, nature sets up this really bad cycle where the atrium actually remodels itself to get worse. Most of the time the body's set up to heal, right? In Afib, it's set up the reverse way. Once you go into Afib, that famous saying, Afib begets Afib, is because the atrium actually changes. It gets bigger, it gets more stretched out, and there's a lot of complex things occurring. So if you've been in Afib for more than a year, we don't know yet when to stop movement of blood thinners. We just don't know. This kind of monitoring technology, we feel better if we know for sure there's no Afib, we feel better in stopping it. Well, thanks. I hope y'all. There's still some food in the back. In fact, if y'all have hungry children, take some sandwiches. And thanks to Sharon. She spends. This is all of her free time. She spends helping with this, so she's really a trooper for helping us with all this.